Afternoon. This is Dr. Bill O'Neill. I'm so honored to be part of this program, and I'm going to be talking today about culprit vessel procedures, culprit vessel PCI, and cardiogenic shock. I know that John Messenger has kind of given the culprit only, and I'm going to give you a contrary view, and I think it'll be great to highlight the differences. The basis of my talk is from our multi-vessel procedures that have been done in the National Cardiogenic Shock Initiative. My colleague, Dr. Alejandro Lamore, presented this data and is published as the first author. I'd like to present this on behalf of all of our NCSI investigators. Well, we know that if you look at the guidelines, they're actually quite dated, but the guidelines really were mixed in terms of the recommendations for multivessel procedures in cardiogenic shock. There is consensus now that multivessel procedures are very helpful and in fact improve survival. In the most recent Complete trial really demonstrates strongly that multivessel procedures are safe and effective in STEMI procedures. Whether or not that's the same in acute MI shock really hasn't been well described. Only one study, the Culprit trial, which I'm sure John has discussed, really looked at this very specific area. And in Culprit, the finding was that Culprit only was superior to multivessel procedures. And we'd like to review that and see what we found in the acute MI shock group. So this is the manuscript that was just published this May in the Journal of Cardiovascular Interventions. We wanted to look at our NCSI database and looked at all the patients that have been prospectively enrolled. At the start of the trial, we told the investigators that kind of use your discretion. If you felt that you needed to do multivessel procedures, it was okay. We didn't either encourage or discourage because at the time of the start of this trial, the culprit vessel trial had not been published. We did discourage, however, the PCI of chronic total occlusions because we felt that in the setting of shock, a prolonged procedure and high contrast load would probably be contraindicated. And so that was really the major difference in terms of the philosophy of our protocol versus the culprit. This is a very busy slide. I would just like you to look to the far right columns. They're the two columns at the end. There are a total of 126 multivessel PCI patients and 72 culprit vessel PCI patients. Our study, our patient population was younger than the culprit, predominantly male patients, and very little other differences. Cerebral vascular disease was very similar. The patients were transferred about a third of the time. Shock was present on admission about 70% of the time. In hospital cardiac arrest about 42% of the time. And the STEMI population was 70%. Now, interestingly, in the SCAI classification, you can see that classic shock was in about 58 and 56 of the patients. In class E, 40% in the culprit vessel PCI group. So a trend towards a higher severity of illness in this group of patients. But by and large, the two groups were relatively balanced in terms of clinical characteristics in the level of shock that was present on admission. In this study, 90% of the patients had Impella inserted before, and then the other 10 had Impella inserted after the procedure. So all patients were supported with mechanical circulatory support with Impella. Right heart catheterization was used to drive hemodynamics in 90% of the patients. If we look at multivessel in the middle panel and culprit vessel on the right, you can see that a trend towards more dye was used, but not substantially much more, 25 cc's more of dye in the multivessel. And I think this is largely because we did not attempt to do CTO procedures in the initial setting. The patients had similar levels of inotropic support. 20% of the multivessel had more than two pressors, and you can see that about 16% of the culprit patients did. And then after the procedure, we were able to substantially decrease the dosage of vasopressors in both of the groups. This is the central illustration that basically reviews the outcomes. So we have 300 patients that started in the National Cardiogenic Shock Registry. We are today to have 400 patients enrolled, but this is a complete data now on this 300 patient data set. 2/3 of the patients, 200 had multivessel disease and 100 had single vessel disease. Well, first, if you look at the single vessel procedures were highly successful and with support had a 74% survival. Now, in the multivessel patients, you can see on the left that multivessel PCI in 126 patients with a 70% survival, in culprit vessel PCI in 72 patients with a 65% survival. Now, this did not achieve statistical significance, but the trend is very different than was present in the culprit trial. In the culprit trial, survival was greater with culprit only, and conversely, we found that the trend actually for survival was increased in the patients that were treated with multivessel PCI. So the one risk with doing these procedures is that if you take a non-culprit and you do an intervention, especially in shock where antiplatelet therapy may not be optimized, you have a chance of causing distal embolization and impairment of ventricular function in areas of the heart that are otherwise normally contracting or hypercontractile to provide compensatory hyperkinesis. And in fact, what we found was in the multivessel group, at 12 hours, the CPO for the multivessel patients was substantially lower than the patients that are treated with culprit only, 0.79 versus 0.91, with a significance of 0.03. And in addition, the lactic acid was higher at 0.48 versus 0.35. So without a doubt, there is transient impairment of left ventricular function, and we presume it's because of microemboli that occur during the multivessel procedure, causing a worsening of ventricular function. However, at 24 hours, the lactate and the CPO were not different between the two groups. So we believe that the patients were supported through the nadir of their hemodynamic support, and this may be one explanation why multivessel can allow for recovery of hemodynamics. So support allows for recovery, and the trend towards worse survival that was seen in the culprit shock trial may actually be negated by the use of hemodynamic support. The fact that all of these patients with had mechanical circulatory support, and it made them tolerant of transient worsening of myocardial function with a trend towards an improvement in hospital mortality. So these are the overall outcomes. You can see again overall survival for single vessel 74%, acute kidney injury in 20%, and length of stay of 8 days. If we then divide the multivessel and culprit vessel, you can see that the survival was 70% versus 65%. The rate of kidney injury was substantial, but this is just basically a decline of creatinine and renal function. We did not have any patients that required hemodialysis in this study. And again, the length of stay was slightly longer. So these patients appear to be more ill than the single vessel patients, but in the end, multivessel patients do equally well compared to the culprit vessel procedures. I want to go back and look at, this is an analysis that we did earlier where we tried to do a more detailed comparison of NCSI versus shock. And this was done with an earlier group of patients. So when we had about 200 patients enrolled, we have substantially more, and we haven't had a chance to update this slide, but I just want to point out a few of the characteristics. The age for NCSI compared to culprit was younger, so I think that's important to acknowledge. The grade of STEMI was substantially greater than in the culprit vessel shock case. The total dose of contrast, and this is, I think, a very important point, was 250 cc's as the mean dose in the multivessel for shock, and it was 200 for the NCSI. And as a result of that, the rate of renal failure was substantially lower. We could take a look at the device. So mechanical support was used in 100% of the NCSI cases. Mechanical support was used in about 20% of the culprit shock cases. So only a minority of patients were supported either before or after the interventional procedure. They had the similar rate of vasopressors. And then one other thing to highlight before the mortality, the TIMI-3 flow was around 84–85% in the culprit shock, and it was around 93 to 94% in the NCSI. And this is an interesting finding that we're finding with mechanical support. We actually are achieving rates of TIMI-3 flow that are in the mid-90s, which is much higher than has been reported in any previous acute cardiogenic shock trials. In the Culprit shock, between 10 and 15% of the patients required renal replacement therapy, whereas none of our patients did. We did see acute kidney injury, but none of the patients required renal replacement therapy. So I'd like to conclude that in the Culprit shock trial, there was a demonstration that multivessel revascularization worsened the overall mortality, at least at 30 days. This study, however, was limited by the inclusion of CTO in a substantial number of the patients. And in addition, only 20% of the patients were treated with mechanical circulatory support. We've now looked at our data in which 100% of the patients had mechanical circulatory support, and we found similar mortality with actually a trend towards a higher survival for the patients that had multivessel intervention without a penalty of having left ventricular renal dysfunction. So we believe that selective non-culprit revascularization in acute MI shock can be successfully performed. We need to make sure that these patients have optimal antiplatelet therapy, because we believe that microvascular embolization occurs in the non-culprit lesions and transiently worsens left ventricular dysfunction. So I'd like to conclude for you that we think that with mechanical support, a judicious multivessel intervention is safe and appropriate and can actually result in a trend towards a higher survival. Thank you very much for your attention.